Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in healthcare IT. And our guest today is Dr. Chip Grant. He's founder and CEO at Watershed Health. Welcome, Chip.
Thank you. Glad to be here.
Yeah, so we have some exciting topics. This is probably the hottest topic in healthcare, it seems, to me at least. But before we dive into our topic, tell us a little bit about yourself and Watershed Health.
Well, I guess the main thing to know is I'm a clinician. I'm a cardiologist. Watershed Health really happened because I was practicing medicine in a busy clinical practice and ran into what really felt like an insurmountable problem. I'm an interventional cardiologist. I was doing a lot of hospital medicine, taking care of very sick, very complicated patients, and ran into a series of events where patients would somehow get through very difficult hospitalizations and then transition into post-acute care. And then have terrible things happen. Sometimes they'd make it back to the hospital with a readmission, sometimes they wouldn't. I've always thought that quality assurance, root cause analysis, performance improvement were really important. Certainly in medicine, that's a big deal. In residency, you do morbidity and mortality conferences, and everybody hopefully is learning from adverse events. And so I started to get interested in looking at the root cause of post-acute failures. And then I got more interested. And then I would say it's not an overstatement that I got obsessed with it. What was really interesting to me was all of the things that I was hearing and reading in the literature about what was going wrong in post-acute care. I didn't see that when I would do an RCA of a specific post-acute failure. And what was maybe even more interesting is I wasn't seeing 50 things going wrong in post-acute care. I was seeing really just a handful of things, and they were happening over and over and over again, causing bad things to happen to these patients. At the time, the hot thing was patient engagement, patient activation, right? It was all about, if we could just get these patients to sort of act right, if they get them to take their medicine and stop drinking and stop smoking and just do what we say, everything would be all right. And, there was this patient activation measure that had gotten really, that was, getting popular, lots of literature about we got to activate it and the patients and when they engage, good things are going to happen. And I was expecting to see a lot of that in this root cause analysis that I was doing. And it turned out that just wasn't the problem. It turned out in post-acute care in this really, really fragile time when patients leave the hospital, it's the providers and their engagement that really matter, that matters. And if you Google or you do a PubMed search on provider engagement, if you do patient engagement, there's like 1 million hits. And if you look at provider engagement, it's like crickets. There's just not a lot there, because it's like, oh my goodness, it certainly couldn't be the healthcare providers that are the issue here.
Interesting.
So what I realized was that really all of these problems that were leading to adverse outcomes sort of boiled down to this issue of provider engagement. When providers engaged, when they communicated with each other, when the right hand knew what the left hand was doing, when they shared data with each other, when they followed evidence-based care pathways, when they did their own quality assurance, performance improvement, patients did well. And when those things were missing, bad things happen. And so what I then said is, okay, perfect. Now here, the problems identified, let's just go find a solution. Let's find a solution that solves for this provider engagement problem, something that can identify provider engagement, and better yet, something that can promote provider engagement, that can actually encourage providers to communicate, share data, et cetera.
Right.
And that just didn't exist. And so that's where Watershed came from. We started in 2013 with really this platform that was aimed at doing just that. Could we create a tool that would help with care coordination, but also identify provider engagement and ideally promote it?
That's really interesting you talk about that problem, because hospital readmissions is such a talked about thing, and we're trying to understand it. And I know I was shocked probably half a dozen years ago when a company, Capsule, told me hospital readmissions was really about post-acute care. In fact, even more so than the home. But everyone was talking about, okay, when we send them home, do we send a device with them or something like that, right? And it's like, oh yeah, when we send them home, we need to prevent them from coming back. And then Capsule opened my eyes to, I think, what you're addressing as well, which is post-acute is as much of a problem or more than the home as far as readmission. So, what did you really find is that key to reducing hospital readmissions? Is it that provider engagement with post-acute care?
Well, first of all, I love the point you just made. And it's interesting as we go around and talk to hospitals, post-acute providers, health systems, that's not a well-accepted concept. Maybe we can blame CMS. If you think about certainly where they aimed all of, think of the 2012, October 2012, the hospital readmission penalty, squarely aimed at hospitals, right?
Yep.
Value-based purchasing, it's hospital, right? Fix this problem, hospitals, and it's a big problem. It's a huge problem. This is a problem that costs billions of dollars. It's associated with a lot of morbidity. I read a paper not too long ago that was looking at hospital readmissions that showed that when patients readmit to the hospital, they have double the mortality for 2 years. Now think about that. There aren't too many things that confer that kind of risk. So it's a big problem. But you nailed it. You absolutely are correct. If you really look at readmissions, the vast majority have to do with post-acute care. It's all about post-acute care. Within only a few days after hospital discharge, hospitals really have nothing to say about whether or not patients readmit. There's some nice papers that actually look at this. And you see that, the quality of the hospital, the transition of care programs that they have, the things that they do matter. And that, that's a given. Hospitals need to do their thing. But very, very shortly after discharge, it becomes the purview of the post-acutes. And we need to also remember, when we say post-acute, we're not just talking about sort of the big five, right? We're not saying, it's hospitals, home health, hospice, nursing homes, LTAC, inpatient rehab. It's post-acute is anybody who's involved in taking care of the patient, both clinical and non-clinical, after discharge, and it's all about them. So this is where it really gets interesting. When you ask what's the key to reducing readmissions, first of all, you got to understand where the problem is, right? Because if you're like CMS and you're beating on the hospitals, and the hospitals are going, we're doing all we can, we're rowing as fast as we can, this is all we got. you gotta aim your focus in the right place, and it's the post-acutes. Now, if that's true, then the next thing that has to be in place, that you have to be able to do, is to tell good from bad, or better from best, right? Yeah, you've got to be able to tell at any given moment. If you've got a patient who needs post-acute care, you got to be able to figure out, where is this patient going to get the best care, where are they going to run into the most engaged provider, which is going to yield the best outcome, right? And that's where we have a big problem, because our existing methodologies really fall short. Now, I'm not gonna pick on any one modality, but the bottom line is, and you can go read the New York Times, you can go look in the JAMA. The bottom line is these claims-based, self-reported measures, metrics, star ratings that we're using to determine post-acute quality just don't deliver. They do not deliver. They don't correlate with outcomes. And that's a huge problem, because now I'm a patient, I'm a doctor, I'm a discharge planner, and I'm trying to find the right place for this patient so we can get the best outcome. And the methodologies that I have in my, are not going to do what I need them to do. Okay. So the first key is understanding the problem. Now, then that brings us to the solution. Post-acute providers need tools for care coordination. We can't just go to them and say, do better, right? Like, just don't have so many readmissions, right? Just do better.
Plus, they don't have the budget to do better in most cases.
They don't have the resources. They don't, exactly. So we can't. So they need tools. They need information. Post-acute providers need to know where is the patient? When did the patient leave the hospital? When did the patient leave the nursing home? When did the patient register in the ER? We can't tell a hospice agency, this patient of yours is in the ER, if they don't know, if they don't have some way of being alerted about that and hold them accountable. They need information about the patient. They need to know what happened in the hospital. They need documentation. They need med lists. They need accurate med lists. They need, data so that they can do their jobs. And up until now, what we've given them is HIEs with these uncurated sort of, data dumping ground things with, care summary documents, which if any clinicians ever looked at a CCD, a care summary document, it's absolutely impossible to.
They get a fax occasionally too, right?
That was the best. I'd get someone would give me a fax for a patient that I saw, a week ago that just came in, and here's the summary. But the point is they need this information, and they really need it in kind of, again, sort of a curated way, right? They don't need War and Peace. They need the Cliff's Notes. They need to know the stuff that they need to know, and they need it just in time. And making them go into 57 portals, because this hospital uses Epic, and this hospital uses Cerner, and this hospital uses Allscripts. So they need this information. They need these tools. The other thing, and you said it, you're exactly right. They are stretched thin already. They have got limited resources, and you go to look at the news right now, and COVID has certainly exacerbated this, but these are not organizations that have a lot of bandwidth and have a lot of time and extra money and extra resources. And so they really need to be able to focus their efforts and their resources on patient care and care coordination, and not all this other stuff. And frankly, including sales and marketing. When you have an organization that's spending a bunch of its resources and bandwidth on, putting together little gift baskets and bringing breakfast to hospitals, you're maybe not spending your resources as well as you could. And so the solution really, we have to provide the tools so that the post-acute providers have what they need to do care coordination, the information they need, and to be able to do these things. We need to, and then what we need to be able to do is recognize and promote their engagement as they spend their resources and efforts around care coordination and not other things, because those are the things that are going to move the needle in terms of patient outcomes. So that's what the solution looks like. And frankly, that was the blueprint for Watershed. Could we create a tool that would enable post-acute providers to do this stuff, to give them what they needed? And then could we recognize engagement? Could we actually use the platform to recognize engagement and to highlight that, to highlight providers that were doing best practice things and that were delivering better patient outcomes, so that they could not, not wonder how am I going to earn this hospital's business? Am I going to bring them breakfast? Am I going to bring them donuts? You're not going to do any of that. You're going to do best practice care. You're going to engage in best practices around care coordination, and you're going to deliver great patient care. And that's how you're going to earn our business.
You're going to stop sending patients back to them. That's the that's the best way to earn the business. But I think there's a lot of organizations, just like you said, right, or things you need to do to really coordinate care. I think that's the best way to describe it, right? Is no one's been coordinating the care, or not many people have been doing it effectively. Which are the organizations or elements? I mean, SDOH is an important topic as well, right? Who do you include in this kind of post-acute network?
Well, yeah, and that's huge, right? So the short answer is everybody. You have to, and if you don't, you're dead in the water before you start. You know this. U.S. healthcare is all about managing patients with chronic conditions, complex patients with multiple conditions. Okay, I'm waiting to meet a patient in a hospital that has one chronic condition. Right?
You don't go to the hospital with that, right?
There are always multiple conditions, and because of that, there are almost always multiple providers, right? Mm-hmm. And so as you pointed out, we can't confine this to just clinical providers. If you're ever trying to explain the weak link in the chain metaphor to somebody, tell them to look at healthcare, chronic disease management in the United States and post-acute care in particular, because that is the place where you really see that if any part of a patient's network drops the ball, you're going to have an adverse outcome for that patient. I've seen many, many times a network of 5 or 6 or 7 providers managing a patient in the post-acute phase. And, the hospital does a great job, the primary care does a great job, the home health does a great job, and the DME company, the durable medical equipment company, the patient's infusion pump goes out on a Saturday, right? And the DME company says, we don't go out on Saturday, right? You've now got an adverse outcome. You've got a readmission. And the fact that everybody else did a great job really doesn't matter to the patient. And frankly, it really doesn't matter that much to the network, because everyone in that network, if they're being held accountable through various mechanisms, is going to pay the price. So you've got to include everybody in these networks with these tools, clinical, non-clinical, social determinant providers. Everybody's got to be working together in the same system. Otherwise, you're going to have silos, and if you have silos, you're going to have fragmentation, and you're toast.
How do you do that efficiently, though? Because it's a lot of work. You look at it, you're like, I think most people will hear this and say, yeah, that makes sense, right? And they've probably lived it. But how do you do this efficiently?
Well, so I hear that a lot, and I thought that when I got started, and I would say with us, what my answer now is, it's really not a lot of work, but that was very intentional, John. We really, from the very beginning, first of all, we're a bunch of clinical people. So we had people come along with systems and solutions and technologies, and then, the next great thing, right? And so we knew that ultimately we were building care coordination networks. And what we knew was the enemy to what we were doing is friction. Okay. And friction comes in a lot of different flavors when you're doing something like this, when you're trying to spread a network or and you can have cost friction. So one of the things we decided from the beginning is we were gonna look to payers to help subsidize the cost, so we could bring this into communities for hospitals and post-acute providers at no charge. Okay, so we're not talking about money. And by the way, we're driving revenue off of savings, right? This isn't so costs. Onboarding and training. We had all done enough of that to know it has to, these systems have to be more like something that you put on your phone than the EHRs that we get abused with. Integrations, IT integrations, connecting the hospital with the nursing home, or the home health agency with the hospice agency. Those interfaces have to be smooth and easy. You have to be able to do that in a matter of hours, right? Not hours, not days, not months. It has to, so I would say that the intentional minimization of friction from the beginning was the reason that ultimately we wound up with what we have, which is now, John, we go into a community with no care coordination platform, either in the hospital or in the post-acute network, and have the whole thing up and running in, less than 4 weeks. Wow. So from nothing to an integrated, coordinated community in less than 4 weeks is really sort of makes you understand the potential.
Well, it seems like the standards have come a long way to be able to do that. I mean, I even think like if they didn't have an EHR, you couldn't even do that, right? Or, I mean, is that one of the keys, is getting access to the data? And now there's some, as I know all their weaknesses as much as anyone, but at least the data is there and available. Is that kind of how it's been the experience? Is that, it's not perfect, but at least it's there and available?
Yeah, and you have to meet providers where they are, especially in post-acute care. I mean, we run into very sophisticated organizations that are part of big national groups that have unbelievable IT infrastructure, and then we work with lots of organizations that are still on paper. And if you aren't able to connect with both ends of that spectrum, again, you're going to have gaps in your network, and you're going to run into fragmentation. So, that's a very important part of this. Now, the good news is it's getting better. It's getting easier. Right. And we've all been talking about like things like FHIR for a very long time, and for a good while, it's just something we talked about. We're now seeing more and more of that, web services, APIs, and things like that make it easier and easier to get connected.
Yeah, so let's talk about some of these technology solutions. How do they help kind of facilitate a continuous improvement process for hospitals that, are using your technology?
Yeah, so that's as you heard me say from the outset, quality assurance in healthcare has got to be a given. I mean, it's literally where Watershed came from. and you know, I learned it in my training, and healthcare people, you know, all across the continuum do it. You know, when when lives are on the line, we don't want to make the same mistake twice, and lives are on the line here. The best organizations have always done continuous improvement, hospitals and post-acute providers. But the problem, John, is that they've done these processes in the same silos, in the same ways that, you know, we have fragmented care delivery. We've had fragmented PI. And the problem with that is you don't see the whole perspective when you're talking about patients that are being managed by networks. I can't tell you how many times when I would look at an RCA, the hospital, for the same patient, the hospital would say, well, you know, if the nursing home had only done this and this and this, and that was, they went away with, that was their takeaway. And the nursing home did theirs, and they said, well, if the hospital had only done this and this and this, and that was their takeaway. And the hospital never knew what the nursing home had thought and said, and vice versa. And so what Watershed does, what our platform does, is to make it possible for organizations to actually collaborate as they are doing performance improvement, as they're working together to understand why things go wrong and how they can make adjustments and improve. And some of the most interesting things we've seen in you know, our time have been related to things that get picked up in this process, and the adjustments that have been made, leading to better outcomes.
Yeah. So I know you use a couple of the solutions from Secure Exchange Solutions to help you facilitate this platform that you're talking about. Can you talk about what's the role of these Secure Exchange Solutions in the work you're doing?
Well, it's, you know, Secure Exchange Solutions is an example of the kind of organization that we just love to partner with, because at the end of the day, what we're really trying to do, as you've heard me say, is to create connections with as many providers as we can, and to not only deliver information to them, but to receive information from them in a way that is going to be seamless with whatever it is that they're already doing. And that's where SES is just fantastic. And through some of the products that we use with them, we've been able to engage with you know, all sorts of providers in all sorts of ways, making better connections, which ultimately leads to better coordination, which, as we've said, is gonna mean we've got patients having better outcomes, patients feeling better, living longer. That's why we're here.
Yeah, so let's talk about their notification solution specifically. You know, what impact has it had, you know, really on the hospital community? I mean, Secure Exchange Solutions has hopped on board with this notifications, which has been, I mean, I think so important legislatively as well. But, you know, what impact has it had on the hospital communities you work with?
Yeah, well, you know, hospitals, hospitals have always, you know, meaningful use, now interoperability has been something that hospitals have had to pay a lot of attention to. We could sort of debate the meaningfulness of some of it,
especially meaningful use, but yeah,
right?
We'll save that for another day.
No, but at any rate, so for sure, what we're seeing from hospitals is a recognition that in order for them to be participating in interoperability, they need to be providing these notifications to providers as patients are leaving the hospital. What we have also seen, though, is not every hospital, but a lot of these hospitals want to do more. They want to go further. It's not just checking a box. They realize that getting this information to these providers in a timely way is going to give the providers an opportunity to do the things that they need on the receiving side of this transition of care. And so that's one of the critical parts of care coordination. It's you've got to know that the patient is left and that the patient needs to be seen. And so that's where that fits in for the hospitals and for us.
Yeah. No, I think it's powerful. And what an interesting idea that they actually care about the legislation enough to take it even further. That's a good example of good legislation. Yeah. And, as we kind of wrap up, I think there's one other topic that's fascinating for me, which, I've always looked at these things like reducing hospital readmissions, right? We talk about every hospital knows their number, right? Because there's so much reimbursement tied to it, money tied to it. But once you've kind of reduced the hospital readmissions, like, how does your platform really help providers continue to ensure that you have positive outcomes for patients? And where do you see other opportunities to reduce hospital readmissions even more? I mean, it's kind of like, when you squeeze an orange, you got all the juice out, like there's no juice left. I mean, how do you see that, right? As far as, ongoing ensuring that readmissions stay low and maybe even find more improvements?
Yeah. Well, I think, first of all, we should acknowledge that the hospital readmission metric, you're exactly right. It's become really the thing that that everyone talks about especially when we're measuring post-acute outcomes. We can thank CMS for that. They made it popular, and I don't see that's going to change anytime soon. Yeah. It's actually kind of it's not by any stretch a perfect metric, and you've probably read and seen or talked to people who can tell you all sorts of flaws in the way that it's calculated, some of the unintended consequences of using that as a metric. But again, I don't see that it's going anywhere. If we say that hospital readmissions is a marker for outcomes and in the post-acute space, what we realize is that it's just one marker. There are a number of other quality metrics that you can think about and you can look at when you're in that 30-day phase. But what's interesting is this sort of arbitrary line that exists at that 30-day point, because it turns out that all the things that are important in the first 30 days when we worry about hospital readmission are just as important on day 31. And
that's interesting.
And day 52. And it's funny, if you talk to health plans, if you talk to payers, they don't really talk about readmissions. I had a medical director tell me one time, he said, we don't really, hospitalization costs us the same on day 6 as it does on day 66. They're all associated with bad things for patients. And so I think that the care coordination and provider engagement is always important. It's important in the post-acute phase in the 30 days where we talk about readmission, which is a very, very tough time, and there's lots of events. And so, it's impacting care coordination and engagement there is going to give you probably the most bang for your buck. But as you get further and further out from the hospitalization, and we shift the terminology, right? We call it chronic disease management. We call it population health, right? I mean, we change our buzzwords, but we're still talking about, patients feeling better and living longer. And a platform like ours that promotes engagement and care coordination is really just as important as you as you go out further and further away, and frankly, for equally for patients that have never been in the hospital. Care coordination is still important. Ideally, patients aren't hospitalized in the first place. Now, in terms of how much juice we can get out of this orange, I don't know. We'll see. Well, first of all, getting the low-hanging fruit, we'll take that. And we've seen some impressive things in our work with communities coming together and really, really driving down readmissions dramatically. Things like evidence-based care pathways that you can start in a hospital and continue into, let's say, a nursing home, and then continue after the nursing home into home health, for example. That's really interesting, because when you can do that and get folks doing best practices and promote that and really see to it that inappropriate variation in care is minimized. I don't know where the bottom is. It's certainly for readmissions. It's certainly single digits, and I don't know how low, but we're gonna go try and find out.
Yeah. Well, this has been awesome. I think your point is so well done, that care coordination is never going to go out of style, right? And technology, like secure exchange solutions and the other work you're doing to bring and coordinate that care, and then to bring that data to the right people at the right time, I think is the core to everything you're talking about and to reducing it. So this was awesome. Chip, I appreciate you sharing your obsession with us. I love people that are obsessed with the topic, because it always makes for a great interview. And thanks everyone for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com. Thanks, Chip.
Thanks, John.